All right, hello everybody. I'm Bradley Stoner, and I am the Secretary for IUCD Canada and also the North American Regional Director for IUCD World. It is my pleasure today to introduce our speaker, Dr. Troy Grennan. Dr. Grennan is the physician lead of the HIV STI program at the BC Centre for Disease Control and a clinical associate professor in the Department of Medicine at the University of British Columbia. Dr. Grennan is an infectious diseases physician and researcher, where both his clinical and research work focus on sexually transmitted infection treatment and prevention, as well as HIV, anal cancer screening, and the health of gay, bisexual, and other men who have sex with men. He is the nominated principal investigator on the Doxycycline Intervention for STI Chemoprophylaxis, or DISCO study, which is a large Canadian RCT examining the role of doxycycline for STI prevention, which is what Dr. Grennan will be speaking to us about today. So welcome to the IUCD webinar, Dr. Grennan.
Thank you very much. All right, so hi everyone. It's my pleasure to talk about this topic today, one of my favorite things to talk about currently. So we'll just get right into it. All right, so first I just want to do a land acknowledgement and acknowledge the land on which I work and live. So with much gratitude, I acknowledge the ancestral, traditional, and unceded territories of the Coast Salish people, and specifically the Musqueam, Squamish, and Tsleil-Waututh nations in the area now known as Vancouver. Just a few disclosures. The most relevant one being the one at the bottom. So I will be discussing the off-label use of the medication, doxycycline, for STI prevention today, and essentially the entire presentation is actually about this. So just wanted to make sure that was clear. In terms of an outline, I'll do a very brief background, and then I'll jump right into summarizing the studies that have been done to date on doxycycline for STI prevention. And we'll be focusing on two different ways to do it, doxyPrEP and doxyPEP. And I'll be covering both. And then I'm going to jump into some sort of implementation issues, focusing on AMR, antimicrobial resistance, and some of the other impacts that doxycycline may have. And then talk a little bit about our study, which you heard about in my bio, the DISCO study, which I'm also very excited to talk about. And then we'll have a little bit of a few points on the way forward from here based on what's currently happened. So by way of background, basically the background and the rationale for what I'm going to talk about today is basically here. This is the slide, and the next slide as well. But this very colorful, busy slide from the Public Health Agency of Canada is really forms the basis of the rationale for this work. So what you can see here is, and I have it on the side here, the numbers. But over the last decade, we've seen significant increases in all three of the main bacterial STIs. So chlamydia increased by about 30%, gonorrhea increased by nearly 200%, and syphilis has increased by nearly 400%. I would ask you to just ignore the part of the graph on each of these infections that shows a dip between 2019 and 2020. This is something we've seen in many different healthcare scenarios. It really is a blip, and what I can tell you, certainly in British Columbia, is that the upward trend has continued essentially unfazed after 2020. So really, this dramatic increase in STIs forms the basis of the rationale for this work, along with, and alongside these increases in the rates, we've seen increases in the complications associated with these infections. So increases in ocular and neurosyphilis cases, in different parts of the world, not just here in BC, not just here in Canada, but in different parts of the world. Antimicrobial resistance, so pan-resistant or basically untreatable gonorrhea continues to be a concern and has been for decades now, and remains one of the World Health Organization global priorities in terms of global health. And then, we're also seeing other more complicated stuff happening, even with chlamydia, where the sort of more invasive serovars causing LGV or lymphogranuloma venereum are increasing and being increasingly recognized and causing lots of morbidity. So that's really the rationale for setting up the rationale for this work that I'm going to talk about today. And before jumping right into the studies, what I want to do is just ask a rhetorical question, because I can't put anyone on the spot. But so just to think about what are some of the interventions that can prevent HIV and STIs. So I'll go through them quickly. So for STIs, we have the usual barrier methods: condoms, testing, partner treatment, and education and awareness campaigns. Bus posters, bus stop posters, etc. And then for HIV, we have all of these, but also PrEP, HIV PrEP, pre-exposure prophylaxis, HIV PEP. In some contexts, circumcision has been shown to prevent HIV, syndromic or suppressive STI treatment, and then the U equals U idea. So the undetectable equals untransmittable idea, or treatment as prevention. And the reason for showing this slide, in addition to the rationale slide I showed, or the background slide I showed, is really to hammer home a couple of points. So the first point being, we have all of these things already. They've been in place, many of these things have been in place for many decades, and yet we still see these increases in rates. So clearly that tells us that we need to do something else, right? We need to do something novel, completely different from what's already happening, specifically around bacterial STI prevention. The other point of this slide is really to demonstrate the clinical precedent for using doxycycline in this novel way, right? So there is a clinical precedent for using medication to prevent infections. We have, HIV PrEP is now standard of care in anyone who is at risk for HIV acquisition. So that's probably the most analogous or clear clinical precedent for the use of this novel use of doxycycline to prevent STIs. So for those of you not familiar with doxycycline, let me introduce you. And apologies for my terrible Photoshop skills, and further apologies for anyone who may be a fan of Barbra Streisand. I'm not, but for sort of bastardizing this poster, I apologize. But anyhow, so doxycycline is an antibiotic that has been around for a long time, since the 1960s, and it's a member of the tetracycline family, and it's a protein synthesis inhibitor. So it works on the ribosomes, it's bacteriostatic, and its half-life, its elimination half-life, is just under a day. It's broad spectrum, so it covers a multitude of gram-positives and negatives, but also many atypicals, including non-bacterial infections. So it covers, Borrelia species, Treponema species, which is, as you may know, one of the species within which syphilis exists, leptospirosis, some mycobacterial infections, Mycobacterium marinum, and then Entamoeba histolytica as well has some activity there. It's generally felt to be one of the friendlier, if I can use that expression, antibiotics when it comes to resistance development and impacts on microbiome. So, it has generally lower rates of C. difficile associated diarrhea, for instance. And when resistance does develop, it generally occurs via impacts on drug influx or efflux. So the cell being able to either pump out more readily or refuse entry, so not allow influx of the drug into the cell, as well as through resistance genes, so plasmids or transposons, and then these ribosome protection genes, which recall that the mechanism of action is through protein synthesis on the ribosome. So if the bug has ribosome protection genes, then it could impact the ability of doxycycline to be active. So as I said, we have a long history of using doxycycline. Over the many years it's been available, not only for treatment of infections, but also for prevention. So as you may know, the other thing I didn't mention was it's also used for malaria prophylaxis. And in many of these settings, it's used for long term, also for the treatment or the prevention of acne as well, right? So it's used for long term, sometimes over a year in folks. So we know it's a pretty safe drug. Its most common adverse events are GI, so people can get esophageal reflux, nausea, that sort of thing. But overall, safe and well tolerated, most people. So before I jump into I want to spend some time going over the clinical trials that have been done on doxycycline. But before I jump in, I just want to define some of the terms I'm going to be using, because it'll just set things up and make things flow a little bit easier. So I'm going to be talking about doxyPrEP and doxyPEP. And so doxyPrEP is the use of doxycycline daily generally at a dose of 100 milligrams, so 100 milligram capsule for STI prevention. So that's daily use of doxycycline to prevent STIs. DoxyPEP is the use of doxycycline 200 milligrams, so 2 times 100 milligram capsules taken after a sexual encounter to prevent STIs. So, and generally the approach with doxyPEP is very similar to the approach that's taken with HIV PEP. So generally you want to take it, the sooner you the better, take it, but generally within 72 hours. And there have been a few studies on this, and different studies have used different maximum. So one study used a daily maximum, and the other studies used a weekly maximum for the doxyPEP approach. Okay, and I'm going to give you a bit of a spoiler alert here. So for anyone who's heard of doxycycline PEP or PrEP, or doxycycline use for preventing STIs, you've probably heard about it because of the doxyPEP approach, because that's the one that has way more data currently on it. Okay, so when we talk about using doxycycline, when it's been in the media a lot in the last half year, it's really based on the work that's been done within doxyPEP. All right, so we'll jump right into the studies. And for the studies, I'm going to be focusing primarily on efficacy. The other analyses I'll talk a little bit about later, but I really just want to hammer home some of the effect sizes in some of these studies. So we're going to start in Los Angeles in 2015 when this study was first published. And this is really the first published study on this approach recently. Okay, so this was a study in Los Angeles led by Jeff Klausner, and it was done in 30 participants, all of whom were MSM living with HIV, all of whom had 2 or more syphilis infections since their HIV diagnosis. And just to go back to this slide, you can see even in the title, at this time, the focus was really on syphilis, to prevent syphilis using doxycycline. It has since evolved. The ideas have since evolved, but initially this study was really looking at syphilis prevention. And they were randomized 1-to-1, so 15 and 15, to 2 different arms. One arm got doxyPrEP, so 100 milligrams of doxycycline daily. The other arm got, this was the contingency management arm. So they got a financial incentive at their study visits if they remained free of STI. So when they went to a study visit, they didn't have an STI, they got money. And so here's really the effect I want to show you. So you can see here in the composite outcome of any STI, doxycycline PrEP worked. So the effect was 0.27, the odds ratio was 0.27, so about a 73% reduction. You can see the confidence intervals here, and the confidence intervals in the p-values are significant. When looking individually at gonorrhea, chlamydia, and syphilis, the effect wasn't seen, but in the overall composite outcome, it's seen. Again, a small study, but promising. The next study is not yet published. It's being submitted for publication, but it's our study here from Vancouver. It's the DUDE study. And similar idea, so we used doxyPrEP. Again, the original idea was to prevent syphilis. And what it showed, what we did was, it was an RCT in 52 participants this time. And we recruited HIV negative MSM or trans women with a prior history of syphilis, I think within the last 3 years. And so participants, and really the point of the study was, it was more of a pilot feasibility study looking at the use of doxyPrEP with HIV PrEP. We want to see how well and feasible they went together. So participants were randomized again to 2 different arms, 1-to-1. All participants, so all 52 got 1 year of HIV PrEP, and of course continued it after, most of them. But the 2 arms got different schedules of doxycycline. So one arm got, the immediate arm got doxycycline daily for the full time, 100 milligrams daily for the 48 weeks, the full year. And then the deferred arm, the deferred doxycycline arm, got doxycycline 100 milligrams daily for the latter 24 weeks, so the last 6 months of the study. And that first 6 months was really meant to act as the comparator. They were followed every 3 months and had the usual standard of care, in addition to a few other things, which I'll talk about later. So here's really the numbers I want to show you. So bottom line is that no one on doxycycline developed syphilis or chlamydia. not surprising, doxycycline is a treatment of choice for both syphilis and chlamydia. So we'd expect that that might have a benefit. The odds ratio for any STI was 0.18, so about an 82% reduced likelihood of having any STI in those receiving doxycycline. So again, that was statistically significant. Again, small participant numbers. This study and the one previous, not really powered for efficacy. That wasn't the original intent of the study, but promising results. Just to put it to a bit more context, chlamydia, there were 10 cases in the deferred arm, i.e. the arm not receiving doxycycline, and none in the immediate arm. So the arm receiving doxycycline, no chlamydia, so 10 to 1. That was significant. One case total of syphilis in the entire study, so not able to say much here. And there was a numeric difference in the gonorrhea cases. So there were half the number of cases in the immediate arm, but again, it wasn't statistically significant. So just for those of you who didn't pay attention, the last couple of slides, I'll just summarize it very quickly for you. So from these two studies on doxyPrEP, 2 pilot studies totaling 82 participants, promising results, but really not powered for efficacy, but looks decent, looks promising. Now we're going to get into really the meat of the evidence here, and we're going to start in Paris. So Jean-Michel Molina, well-known clinician and HIV and STI researcher, he did the first study really on doxyPEP, and it was a sub-study of an existing study on HIV PrEP called IPERGAY, which was, as many of you may know, was a clinical trial that demonstrated efficacy of event-driven or intermittent HIV PrEP. And so this was published in 2018. He randomized 232 participants to one of 2 arms. So one arm received doxyPEP, so 200 milligrams after a sexual encounter. The other arm, and it was open label, the other arm received no PEP. This study had a maximum dose of 600 milligrams per week, or 3 doses, 3 200 milligram doses per week. And what it showed here is, so these are the Kaplan-Meier curves for the different categories of outcomes. So the one up here in the top is any STI, and the others are the individual STIs. What you can see, just even ballparking or eyeballing this, is that basically everything seemed to have an impact. So every category, there was an impact in every category except for gonorrhea. So you can see the Kaplan-Meier curves are basically at the same level, but for the composite outcome of any STI, chlamydia, and of syphilis, there's a difference in the efficacy. So you can see, didn't seem to work for gonorrhea, but worked for the other 3 categories. So the next place we're going is to my neighbors in the south of here along the western coast of the US, so Seattle and San Francisco. This study was led by Annie Lukemeyer and Connie Kellum. And if you've heard about doxycycline PEP, it's probably because of this study. So this study was published in the New England Journal earlier this year, but it had been presented about a year before at the International AIDS Society conference in Montreal. And this is the one that this study got a lot of media coverage. So if you've heard about this intervention, it's probably because of this one. So what they did here was they had planned on recruiting nearly 800 people. And they were recruiting them again to overall to 2 to 1, actually, to doxyPEP versus no PEP. So 2 to 1, 2 doxy, 1 no PEP. And they broke it down. So they were all getting the same intervention, but they broke it down to folks living with HIV and to folks who were taking HIV PrEP. But basically, they got the same intervention. So 200 milligrams PEP of doxycycline. And so what happened here is, though they hadn't expected to recruit nearly 800 people, the Data Safety and Monitoring Board of the study shut it down early because of efficacy of the doxycycline arm. They said you have to stop, and you can no longer not give people doxycycline because of the efficacy. So it was stopped when there were about 500 participants recruited. And here are the results. So just again, eyeballing this, you can see a clear difference. So this is just broken down by the 2 different cohorts. Again, the same intervention. You can see it broken down by doxyPEP to standard of care. So standard of care is no doxy. Clear difference in STI incidence per quarter, which was their primary endpoint. And then in the persons living with HIV cohort, the same thing. And if you look at the overall effect size here, total for any STI, it was about a 65% reduction. Okay. Then we break it down by the different infections. Same idea. Eyeballing this, you can see there's an effect on all three of the infections. And so eyeballing it is one thing, but actually stats are another. So here are the stats. And so there was an effect, a good effect on all three: gonorrhea, chlamydia, and syphilis. The one thing to note, though, as you can see, is recall that the French study that I just showed you, presented, there was no effect on gonorrhea. Okay, just keep that in mind. But there was one here. You can see statistically significant in both cohorts. You can see the effect on gonorrhea, though, is dampened, right? So it's about 55% versus close to 80, close to 90 and mid 70s. Again, close to 90, high 70s. So you can see there's an effect on gonorrhea, but it's dampened when you compare it to chlamydia or syphilis. We'll talk about that later. And then, so finally, we're going back to Paris. Same guy, Jean-Michel Molina, did this study as well. And what he did here was a little bit more complicated than his previous studies. This has not been published yet, I don't think either, but it was presented this year at CROI, the conference CROI. And what he did was, it was a 2x2 factorial design. So basically what he did was he had folks enrolled. So they were MSM on PrEP. And he had them enroll, and there were two interventions. So doxyPEP, as I already described, but also the conjugate meningococcal B vaccine. So, and it was a 2x2 factorial design. So, some people got doxy and other people got no doxy, and then people got, so it was 2x2. And without getting into the details, any more details of the design, which is a little beyond the scope of the presentation, I just want to jump into the results. So for the other thing to note as well, which is important, is that there was the analysis they did allowed for them to know that there was no interaction between PEP, the doxyPEP, and the vaccine. So the effect size you're seeing here is from doxyPEP. So this is what happened with doxyPEP, with no impact or no interference from the vaccine. Okay. So the other thing to note as well, which I forgot to mention at the beginning, is that this study was also halted early by their DSMB. So they meant to recruit, I think, 720 participants, and they only recruited 546 before they were told they had to shut things down because of doxyPEP efficacy. So what you can see here is that for a first chlamydia or syphilis infection, there's a clear difference. There's a happy face to tell you that that's a significant result. So in the no PEP arm, you can see the probability of having an STI was higher compared to the PEP arm. Right. Next slide. So you can ignore, this is mycoplasma. You can ignore this for now. So for gonorrhea, again, surprisingly, they did see an effect, and it was statistically significant, as indicated by the happy face here. So just remember again that the first study that Molina did, there was no smaller numbers, 232 participants, no impact on gonorrhea, but this study did show an impact on gonorrhea. Just keep that in mind, because I'm going to talk about it a little bit later. And one more study. So all of the studies I've shown so far have been in MSM and trans women. Not all had trans women, but were in a combination of MSM and trans women. There's been one study, again, I don't think it's been published yet, I haven't seen it, that enrolled cisgender women in Kisumu, Kenya. And this was a clinic-based cohort of women who were already receiving HIV PrEP. And what this showed was that there was no effect from doxyPEP. So you can see the effect here, the confidence interval and the p-values, no effect for any STI. You can see the Kaplan-Meier curves don't look great. So just to briefly summarize what I just showed you, so far, at least in MSM and trans women, there's data from 3 large studies totaling nearly 1,300 participants that demonstrate significant efficacy for doxyPEP in preventing STIs. Okay. And this is just a big, busy chart where I summarize kind of all the studies. These are the doxyPEP studies, promising but small sample size. These are the doxyPEP studies, good efficacy, and then the Kenyan study, which didn't show a difference. So just as a reminder. I'm now going to jump in for the second part of my presentation. I'm now just going to jump into some unanswered questions and unresolved issues around the use of doxyPEP and doxyPrEP. And these are going to focus on the differential impact on gonorrhea, which I've highlighted throughout the study reviews, the impact of doxy on antimicrobial resistance. And let me tell you, this is probably the biggest question that exists in this realm. It's the question I get the most often. It was probably the reason for our multiple grant rejections when we were first trying to get this work funded. So it's an important part of it. The other question is around the human microbiome, like what are the impacts on other parts of the body in terms of the makeup of the bacterial populations and the function of these bacterial populations in other parts of the body. How does doxyPEP and PrEP, or how will it perform in other populations? We've seen one example where it didn't perform well, but what are other considerations, and then what future work is planned, where I'll get to talk about DISCO. So let's start with gonorrhea. So why the differential impact on gonorrhea? So just as a reminder, there's been conflicting data, right? So that first French study I showed you didn't show an impact on gonorrhea, but the second French study did, the US-based study did. Our small study had a numeric difference, but it wasn't significant. So what does it mean? And even in the study where there was an impact, in both studies where there was an impact, so in the doxyPEP study, the US study, and in the doxyVac study, the more recent French study, there was an impact on gonorrhea. It did reduce gonorrhea, but the effect was dampened compared to, at least numerically, compared to syphilis and chlamydia. So one of the reasons is probably there are different rates of resistance in the US versus France when you're looking at resistance of gonorrhea to tetracyclines. So in the US, it's lower. It's estimated to be about 30%, whereas in France, it's estimated to be about 60%. Just as an FYI, in Canada, our numbers are likely closer to the French numbers, from what I've been told by folks at the National Microlab. But what these results, especially the more recent French results, tell us is that even in the context of high baseline resistance, there's likely still a preventative role for doxycycline to play when you're thinking about gonorrhea prevention. So that's an important point. Second question is, what is the impact of doxycycline on antimicrobial resistance generally? And when we think about AMR, we think about a number of things. The things that come to my mind are, I think of two categories. So there's the STI category. What's the impact of AMR on the STI bugs we're worried about? And what is the impact of doxycycline on AMR in other bugs? So what we call off-target organisms. So there's little data from the completed studies so far. Many of the studies have ongoing work that have just not been analyzed or published yet. But a couple of key points is that antimicrobial resistance to tetracyclines has never been documented in syphilis or chlamydia yet. I'm not just speaking about these studies. In general, it's not been documented. Certainly it's been documented to gonorrhea, but not to the other two organisms. And that's key because we do rely on doxycycline as actually a preferred treatment for chlamydia, but also a recommended treatment for syphilis. So if we were to find evidence of resistance in either of these organisms, that would be a problem. That would be a first. The other challenge, though, is that though gonorrhea is relatively easy to culture, which is the easiest way to determine antibiotic susceptibility and resistance, you just throw it on a plate and slap on some antibiotics and see what grows. You can't really do that with syphilis or chlamydia. Basically, syphilis can't be cultured unless you're in a very specialized lab with lots of experts and lots of patients. And then chlamydia, same thing. You can't really do much in terms of culture plate-based resistance testing. So you rely on molecular methods, many of which are still very much kind of exploratory. So it's hard to monitor this. But like I said, we do care more about resistance in these two organisms because we rely on doxycycline for treatment. But we also need to think, and we should continue to monitor, and we will in the studies continue to monitor impacts on gonorrhea resistance, because there's still an impact there in terms of preventing. So it's important to monitor and make sure we're hopefully not having an impact on resistance development. We also need to consider AMR and off-target organisms, so things like commensal organisms in the oral flora, staph, strep, that sort of thing. Our team, led by Daryl Tan in Toronto, did do a systematic review a couple of years ago as we were starting to do some of this work. And it was a systematic review on the impact of tetracyclines on antimicrobial resistance in normal human flora. And very poor data quality, unfortunately. There wasn't a lot of good data out there. But it did show a slightly increased burden in subgingival or oral respiratory and GI bugs, but no persistent AMR was seen. But again, the data quality was poor, but reassuring. But again, there hasn't been a lot of good work done in this area so far. And this is just a quick summary of AMR in both gonorrhea, but also in off-target organisms that have been analyzed thus far in the studies that have been done. So in the doxyPEP study, so in the US study for gonorrhea, there was about, again, these are all small numbers, so please take that into consideration, fewer than 20 in most cases. At baseline, there was 4 of 15, or 27% of the gonorrhea had resistance to tetracyclines. And then over the course of the study in the doxyPEP group, 38% versus 12% in the standard of care group. But again, small numbers. And then in the doxyVac study, so the second French study, all 65 cultures of gonorrhea that they did had demonstrated AMR to tetracyclines. Looking at off-target organisms, so specifically Staph aureus in these two cases, in the US study, there was lower Staph aureus carriage in the doxyPEP group, so the group receiving doxycycline, and marginally higher rates of AMR to tetracyclines in the doxyPEP group versus the standard of care arm. But again, it was 5% versus 4% and very low absolute numbers. In our DUDE study, there was also low Staph aureus carriage, 9 in the immediate arm and 12 in the deferred arm. And AMR was noted in 5 isolates in the immediate arm and 1 in the deferred arm. So again, and not significant. So again, very small numbers, needs more work. The next question that comes up is the impact on the human microbiome. So a lot of people don't even know what the microbiome is. It's really hard to, it is hard to describe it. And also, a lot of people ask, like, so what? Like, why do we care about the microbiome? It's this, nebulous thing that I don't know a lot about. So the human microbiome is, very simply described, is the collection of bacteria, viruses, fungi, organisms that populate, microorganisms that populate your body. There have been definite associations made between the microbiome and health outcomes or disease. So there's strong associations between the human microbiome and asthma, for instance, obesity, other chronic diseases. A lot of them related to antibiotic use. So antibiotic use can cause perturbations in the human microbiome. And then when you're looking at, more closely, when you're looking at anatomic-based microbiome, so let's say, for instance, the cervical or the vaginal microbiome, there's been a lot of work done in this area, looking at various things. So impact of the microbiome. So again, shifts in the populations of organisms affecting HIV transmission in that specific anatomic area. Also within the cervical microbiome, there's been work looking at the impact of the microbiome on progression of cervical precancers. So in our studies, and in many of the studies I've talked about, there are microbiome analyses planned. This is from our DUDE study, and I couldn't explain this very intelligently to you, this figure. It was done by someone who's an expert in microbiome, Adam Bergner, who's based in at Case Western Reserve in the US, formerly from the NML. So he did some work for us on our DUTE study. And basically what it showed was, in our small numbers, so in the 52 participants that we had, there was really no difference in microbiome composition. Okay, so we just looked at composition. There's other kind of microbiome work you can do, looking at function and metabolism and that sort of thing. We just did composition. And there was no difference. So that's reassuring, right? It didn't seem to have huge impacts on shifting the microbiome in any kind of way, but further work needs to be done. Next question is, how does and or will doxyPEP and PrEP perform in other populations? So as I presented the brief slide from Janelle Stewart in the US, who was a PI on the DPEP Kenya study, it showed no impact there. And so the original presentation of that data was at CROI earlier this year, and then she followed it up with a presentation more recently in the summer at the International STI conference, where she actually talked about reasons why it didn't work. And it seems to be, I have just a screenshot of her slide here, but it seems to be efficacy. So nearly 50% of those individuals who'd been assigned to the doxycycline PEP may not have taken any doxycycline. That was based on hair analysis. So you can do hair analysis for adherence testing. So, this brings up a number of different questions. So what would the efficacy be in non-MSM and non-trans women populations in other contexts? So, a US, let's say like a US or a Canada-based population of cisgender women at risk for STIs, would there be a different impact? Do we need to consider in certain populations a role for enhanced adherence measures? And again, is there a role for doxyPrEP? So we don't know. There hasn't been enough data done or enough research done in doxyPrEP to know whether or not that might have an impact. The other thing I'll just mention about doxyPrEP is, as I said, and as I presented, there's been much more data on doxyPEP, confirmed efficacy of doxyPEP in these populations as a STI prevention strategy. And the assumption many of us have made over the years is that people will prefer doxyPEP because it's probably will work out to less drug in most people. But I don't think we can make that assumption, because I think when you actually speak to people, folks taking doxycycline, and I do have a number of people off study who are taking this just in my regular clinic, people have different ideas about it. Some people actually prefer to take it daily because they already take HIV PrEP, or they take some other medications daily. They prefer to take it, easier to remember. So there's a lot of things that go into the different interventions, and so we can't make assumptions about what would be preferred or what would be better from an acceptability point of view. All right, so now the last thing I really wanted to focus on was what future work is planned, and that really will bring me to our DISCO study, which is a study we're running here in Canada. So DISCO stands for doxycycline as an intervention for STI Chemoprophylaxis. And it's a funded study that's a national multi-center study where we'll be recruiting 560 MSM and trans women. And the study sites are in Vancouver, Calgary, Hamilton, Toronto, Ottawa, and Montreal. It's a 2-arm non-inferiority trial. We'll be randomizing folks 1-to-1 to one of 2 arms. So STI PrEP or doxyPrEP. Sorry, I'm using those interchangeably. Or STI PEP or doxyPEP. And this originally was designed as a 3-arm trial with a standard of care arm, but when the results came out, or the press release came out from the US doxyPEP study that had been shut down or halted prematurely, we felt we needed to remove that standard of care arm as it was no longer ethical to include it. So the objectives are pretty standard. So we're looking at the non-inferiority of STI PrEP versus PEP. So the efficacy in preventing STI, we're looking at a number of other measures, including AMR, and then we're also going to be doing some modeling studies led by Sharmista Mishra in Toronto. So the eligibility criteria match pretty much the other studies that have been done. So MSM or trans women, sexually active and the intention to remain sexually active, and a bacterial STI in the last 12 months. So that matches the eligibility criteria from most of the other studies. Just as a little update, so this is our website, godisco.ca if you're interested. But we began enrollment at our Vancouver site in mid-June. And as of now-ish, we've recruited about 50 people, 50 participants, which for those of you who may not be involved in clinical trials is quite impressive. I take almost no credit for it because I have an amazing team of people who are working really hard on this study. And so it's quite impressive. There's a lot of people very interested in this. Our site goal for our Vancouver site is about 200 people. And we've already recruited 50 of them, and we have a wait list of about probably 150 people still who are interested. So the other sites are going to be ready to go. Well, Calgary's already ready to go, and Ontario and Quebec sites are going to be ready to go soon. So I suspect it's going to be pretty successfully recruited study, fingers crossed. The last thing I want to talk about, because I don't often get the opportunity to talk about this in much detail, is the modeling work that will be happening, because I think it's a really important part of our study and will really help inform some of the implementation pieces for doxycycline as an intervention for STI prevention. And like I said, this is work that's being led by Sharmista Mishra at Unity Health Toronto, so former St. Mike's at U of T. She's an ID physician, but also has a PhD in mathematical modeling and does a lot of really cool stuff. So her team will be using a range of data, so external data, which includes sexual behavior surveys, but also internal data collected within the DISCO trial itself, so costs, sexual behaviors, etc. Looking at how the impact doxyPrEP and doxyPEP have. She'll be focusing on syphilis transmission, but I suspect there'll also be some work done on the other STIs as well. And really just looking at the impact of these interventions depending on various degrees of coverage of doxyPrEP and doxyPEP. She'll also be looking at what epidemiologic, demographic features of the sexual network and the syphilis epidemic stage, how that influences the impact of PrEP and PEP on the syphilis epidemic, to what extent doxyPrEP and PEP could reshape the epidemic. She'll be looking at stuff I don't understand very well, but dynamics, mitigating rebounds in syphilis across interconnected sexual networks. So lots of network and epidemic work. And then finally, her and her team will be looking at costs and population health benefits. So some of the more, I guess, more well-known to most of us, cost effectiveness work as well. And finally, my last slide here, I just want to talk a little bit about the way forward. So I think if there's one thing that's clear from the data so far is that doxyPEP efficacy is established in the key populations of MSM and trans women. I think we can confidently go forward and say this works to prevent STIs. There's still a lot of work required around implementation, and a lot of unanswered questions that I think certain people would feel more comfortable if they were answered a little bit more comprehensively. So, questions around AMR and microbiome, of course, are always coming up. But even just more directly related to specific implementation, so how best to provide this intervention. Probably at the point of care, ensuring that we're reducing any potential barriers, because, as we all know, syndemics play a role in a lot of the work that we do, and we want to ensure that, especially in the context of sexual health care, we're providing the lowest barrier care as possible. So not having people have to jump through hoops to access this important intervention, which also fits into the acceptability, right? So what do people, and also preferences. So what do people prefer in terms of how to have this delivered, by whom, and what modality? So if doxyPrEP, which we'll be looking at in the DISCO study, is shown to be, non-inferior to doxyPEP, that will then become, I think, a reasonable intervention to consider in certain people. Another thing to think about, which I think is maybe a little premature, is guidelines, specific guidelines to recommend this and how to use it. There have been a few local guidelines produced. So specifically, San Francisco Public Health, which I have a screenshot of up here, produced guidelines almost a year ago now. but also more recently, Seattle-King County produced some guidelines as well. What exists more commonly in different jurisdictions is our position statements. So there's one here on the screen, which is from Australia, but BASH, so the British Association of Sexual Health and HIV, has one as well, and they're kind of position statements, and they're not recommendations, and they don't recommend, actually. In many cases, they sort of think we need to wait a little bit. So it's still it's dynamic, and it's going to change. But I think this is all stuff that our work and others' work is leading up to. And there's still a lot of work happening within the studies that have been completed. There's still a lot of analyses happening, and a lot of further work planned. So with that, I will end. We'll just pull up my acknowledgement slides, and I'm happy to take questions.
Okay, thank you, Dr. Grennan. That was fantastic. And I am going to take the liberty of fielding some of these questions and allow you to answer them as you feel fit. First question, Dr. Grennan, for gonococcal infections, do we know infection site and if doxyPEP prevented pharyngeal infection as well as urogenital?
So off the top of my head, I do not remember. They did look at this in the doxyPEP study for sure, in the US study. And I don't know if I saw that data, and if I did, I don't remember it. It definitely worked at all sites, but I don't remember if there was a differential effect. But that's an excellent question, and I will note it to look it up, because I don't know if I actually know that or not.
Okay, perfect. And what about for studies that had an effect on gonococcal prevention? You talked a little bit about tetracycline. Is there information on tetracycline MICs in the regions that these studies were conducted? So say the Kenya study. Do you know much about that?
So yeah, I didn't go into much detail on the DPEP Kenya study, but that study actually really was only looking at, in terms of the prevention targets for the doxycycline, it was really only looking at chlamydia, because gonorrhea, high resistance rates to gonorrhea in the area where it was done. So they didn't even, I don't think, considered it really. And there was very little syphilis consistent with other areas in the region. So they were really focused primarily, the Kenya study was really focused on chlamydia.
Okay. Are you, just as an aside, I was, your microbiome research was, as you said, reassuring, certainly people are on doxy for other reasons than STIs. Do you feel that there will be, eventually selective pressure that emerges as a result of this, if it becomes more widespread? And what would that look like in terms of particularly around gonorrhea and chromosomal resistance?
$1 million question. I wish we knew. When you speak to experts, and I would not consider myself an expert in the area of antimicrobial resistance, I will just say that this is not me speaking. The experts, folks who know much more about this than I do, at least when it comes to the development of resistance in syphilis and chlamydia, many people feel that's much less of a concern. They don't feel that's likely. Mm-hmm. Gonorrhea, whether this will drive increasing resistance, possible. But I think there's some people who don't think it's a concern as well, and others are just unsure. I think that the jury is definitely still out. That's why we really need to, there's a few things we're really trying to do in our study, and other studies have done it. They just haven't reported a lot on it yet, because I think they're still analyzing, is we're really trying to culture every single diagnosed gonorrhea infection we get, so that we can get the antimicrobial susceptibility and resistance, and do that over time. But also the key thing, and this is something that Annie Lukemeyer from the US study really pushes every time we talk about this, is the importance of doing a test of cure. And anyone who's diagnosed with an STI in these studies and who's on doxycycline, yeah.
Yeah, of course, culture is harder and harder to come by these days, because people are using molecular tests. All right, there was the related question. I think I sort of addressed that ahead of time. Doxy is given for acne daily. Is there any study with that daily dose on STI prevention?
Not that I know of, not directly. There's a lot of work on doxies in there's a lot of Durham papers on doxy.
Yeah.
And so some of those actually, some of them were included in a systematic review. I don't know of any that directly looked at STI prevention. There could be, I don't know offhand if there are any. Yeah, I'm not sure.
How about the next question, Dr. Grennan? If doxyPEP or PrEP are given and syphilis is acquired, does it affect the assessment for stages of syphilis? In other words, RPR test results. Do you know much about the impact on clinical presentation?
We don't know. That's a really good question, and that's a question we all have. Yeah. We don't know if it hasn't. We haven't seen a signal, as far as I know, in any of the studies. But and the good thing about these studies, but also the good thing about the populations in which these studies are happening, is that generally they're folks, assuming they're still sexually active, they're folks who are generally regular screeners. So at least we will be able to capture any change. But that's a really good question that I don't think anyone knows the answer to yet.
How about the DISCO study? A lot of interest in that among our audience. How can people enroll if they're interested? Do they need to be Canadian residents? Can international students, international workers, people mid-immigration enroll?
So, so a couple of things. So it does require, so you can go to our website. Okay. I will pull it up. Where was it? Here it is. Maybe you can't see it, but it's godisco.ca. Or you can just email me. It's easier. But a couple of things. So there are in-person study visits, and there are, it's quarterly, but there's a baseline and a 4-week, and then quarterly for a year, for 15 months actually. So you have to in-person study visits. Couple of logistical things. So as long as you're in or willing to travel to one of the cities where there's a site, it's possible to enroll. There are waiting lists, it's like an exclusive club these days.
There are, yeah.
Yeah, there are waiting lists. I know, I know in Vancouver, we're kind of feel like we've been saturated. But I would encourage people to contact me if you could. With respect to the, it depends on the your question around folks who are non-residents. Some of the blood work that gets done is standard of care, so it gets done just at least at our site, it gets done at an external lab, because we actually can't do some of the stuff, some of the the ALT and the AST and stuff. So it gets done at life labs generally. So that would require a health number unless they were able or willing to pay for it themselves. It's just many of the clinical sites don't have labs on site that can process things in a way, and being that it is standard of care, it's just done through routine channels. So that's the one barrier that might be there for folks.
And then the doxy, I mean, certainly in the study, I guess people aren't paying for it. Is publicly funded, research funded, or is there a cost to the client?
No cost. So they and in fact, they get a stipend. Typical study visit stipend, primarily to cover any kind of expenses they may have had, parking or whatever. They get a stipend per visit. So there's certainly no cost. The cost of the doxycycline is covered by the study funds, and I don't know of any public programs that cover doxy. I think I'm fully supportive of necessary medications being covered. I'm a proponent of universal pharmacare, I guess I could say, but for this one, I think it might be a little early to roll out like an organized program for. I think we still need to. Even just from an optics point of view, I'm very supportive of it. And of course, I've dedicated the last, 5 years of my life to looking at this. So obviously, I'm the biggest cheerleader for doxycycline for STI prevention. But I think, there's some work that needs to be done before we can start talking about some of these sort of more what I feel are a little bit more downstream issues. But certainly, I would support the cost, support the eventual funding of such a program. It's all in all, it's a very cheap medication, right? but still, like I would certainly support it being funded once we've established its role and how to roll it out, et cetera.
Have you heard, related question, I'm going to slip in, have you heard of any off-label use of doxy? In Ontario, of course, doxy is available through pharmacies for post-tick bite, Lyme disease prevention. And we've heard anecdotally that some people are actually going to pharmacies and getting doxy for other reasons. So wondered if you're seeing that in BC or other parts of Canada.
All over the place. I hear about it all the time. Yeah, of course, it's happening. Way back after the first doxyPEP study, that first French study that was published in 2018, there was the UK, actually, the BASH, that British Association of Sexual Health and HIV, came out with a statement at that time saying, we have heard that people are buying, because online pharmacies that were selling HIV PrEP were actually started selling doxycycline because of this study. And so they put out a statement saying, like, we need more, like at that time, we need more research, stop. So it's definitely happening. And the use of doxycycline for STI prevention is off-label, right? Even in our study, it's off-label. Our study, by virtue of the fact that we're using an off-label indication, we had to get Health Canada. It's a Health Canada study. We had to get Health Canada approval for it. So any use of doxy for this reason is off-label. But it's definitely happening. And even in our clinics here, I, along with many of my colleagues here and in other parts of Canada, are using it in some patients off-label. So outside of the study context for STI prevention. So
the following question then is, in terms of PrEP versus PEP, you think the focus should be on doxyPEP, given that you'll be using fewer doses and therefore lower population exposure?
Well, in theory, yes, but in Vancouver, we're a bit of a weird island here, I think, when it comes to doxycycline, because we've been doing some of these studies for so many years that I think there's certainly a community awareness that this is happening, and through studies and that sort of thing. So Mark Hall, who's the other PI on the study, and I in Vancouver, and then Daryl Tan and Birchall are the Toronto PIs. So Mark Hall and I have been doing these studies for a number of years now. So many of our patients, after they finished the DUDE study, which was the doxyPrEP study, they wanted to continue. So many of them have continued doxyPrEP. I would say that overall, and in speaking with Mark, it seems that he says that about of his patients who are on doxycycline, about a third might be taking it the PrEP route, and about 2/3 take it the PEP route. But many of these people may have started before the evidence was so clear, because it's been around here for a little bit longer than I think other parts of Canada. So, but I think if you're going to go based on the evidence, you kind of need to go with doxyPEP. So that's what I would sort of favor. But I suspect that using a combination of patient preference, and if we can show efficacy, or at least non-inferiority with the DISCO trial, it shows that it works as well, which I anticipate will be the case, then we can kind of go with patient preference. Because again, like I said, in speaking to people, some people would actually prefer to take it daily because it's easier to remember.
We just have one more minute, but I see Dr. Mark Stebbin has joined us. He is the IUCD Canada president, and maybe I'll invite Mark to close us out. Mark says just arrived. Next webinar is 18th of October with Dr. Karen Lithgow about STI and pregnancy. Mark, take it away.
Yes, thank you very much. I was not able to join. There was a problem with the train between Quebec City and Montreal. So thank you, Brad. Troy, I promise I will listen and your recorded webinar and send you some boiling questions about this topic of the actuality. And I would like to thank also Greg Penny for organizing. And as Brad said, we will have Dr. Karen Lithgow about STI and pregnancy on the 18th of November. So thank you very much for joining.
18th of October. October
18th of October.
Yeah.
Thank you all.
Okay. Thank you. Thank you, Troy.
Bye.
Okay.
Bye-bye.